Welcome to the Behavioral Medicine Foundation's course EEG Biofeedback, Assessment and Intervention. I'm Cynthia Curson and I am your instructor. If you have any questions or comments or where do you send your review questions, you can send them to the email that's listed at the bottom of this slide, cynthiacurson@gmail.com. Or you can also contact Dr. Sherman for any other needs, and you can contact him by his email listed there below. It's easy to get through the PowerPoint presentation. You put it in slide presentation mode, and then you use your arrow keys to go up and down. And you'll have the option of listening to the slide or not as you go on. I look forward to working with you. In this section of the course, we will discuss what neurofeedback is, what operant conditioning is, and a little bit of history around that in behavioral medicine, and the history of neurofeedback and EEG and QEEG as well. This is Dr. Rich Sherman, if you've never seen him before, and as you can see, he's got a very good sense of humor. And this is me, Dr. Cynthia Curson. This is our text, Doing Neurofeedback and Introduction, written by Richard Sauter and Robert Longo. It's published by the ISNR Research Foundation, so all of the proceeds go toward research through our foundation. You can purchase the book at, as you can see there, www.bmedpress.com. And if you haven't already done so, and the entire book is not required. It's only selected chapters. You'll see that in your outline. But feel free to read the book because it's a good one, even the sections that are not required for this course. Let's start off with the definitions, the official definitions of neurofeedback. And there are two. The first one has been written by the BCIA, Biofeedback Certification International Alliance. And they state it as, neurofeedback is employed to modify the electrical activity of the CNS, including EEG, event-related potentials, slow cortical potentials, and other electrical activity either of subcortical or cortical origin. Neurofeedback is a specialized application of biofeedback of brainwave data in an operant conditioning paradigm. We're going to talk about that quite a bit during this section of the course about what exactly operant conditioning is and how it is applied in neurofeedback. The method is also referred to as neurofeedback. The method may serve as the basis for neurotherapy, treatment of a clinical disorder, or performance enhancement, the enhancement of normal functioning. There's a big difference between the clinical application and the application of peak performance training. There are a lot of implications for doing clinical treatment if one is not legally licensed, certified, qualified to be doing treatment for certain indications that are not within their scope of expertise or licensure. The ISNR, International Society for Neurofeedback and Research, has a much longer description of neurofeedback, and you can read the rest of it on their website, which is isnr.org. What they say is, like other forms of biofeedback, neurofeedback uses monitoring devices to provide moment-to-moment information to an individual on the state of their physiological functioning. The moment-to-moment piece is very, very important. You have to couple your reward with your activity as closely, temporally as closely together as possible. The characteristic that distinguishes neurofeedback from other biofeedback is the focus on the central nervous system in the brain. So neurofeedback is, in fact, a biofeedback modality that works with the central nervous system and not the peripheral nervous system, which is the heart, the muscles, the blood vessels, and breathing training, electrodermal activity. So that's the only difference. Neurofeedback is, in fact, a modality of biofeedback. Neurofeedback training has its foundations in basic and applied neuroscience as well as data-based clinical practice. So that means that there is a lot of research that shows that in neuroscience that shows that neurofeedback is an effective modality, but it is also based upon the data that has been derived by many clinical practices and single case studies and anecdotal publications. It takes into account behavioral, cognitive, and subjective aspects as well as brain activity. So neurofeedback can be a training tool, but there is so much more involved with the person in order to make it so that what you're doing to the hardware, the brain, you are also doing to the software or the psychology of the person being trained. As I mentioned in the last slide, there's a difference between the hardware and the software. The hardware being the brain, the software being the mind. So as applied psychophysiologists, we are managing both of those things. The psycho is the software, is the mind, and the physiology is the hardware, is the brain. And I think this is a great analogy when you are thinking about how you're working with your clients, in that if you have licensure and expertise in psychology, you can use those skills. And if you have licensure and expertise in the physiology aspect, well, then you can use those skills as well. However, when you're doing neurofeedback, you are a psychophysiologist. And so it's really important to realize that you're training the hardware, but you're also affecting the software, the mind, in a very large way. Your book mentions many neurofeedback experts. I would like to just pass on a few more names of people who have contributed to our knowledge of how the brain works, and therefore strengthened our notions about what it is that we're doing and what it is that we're actually training. Here you have the two fathers of EEG, Richard Caton, who measured the electrical nature of the brain in animals, and Hans Berger, who was the first to measure brain's electrical activity in humans. You could learn a lot more about these two gentlemen in Wikipedia, and there's also some mention of them in your textbook. Happy to have dialogue about them with you. The important thing is for you to know who they are and how important their discoveries are to our field. Here you have what most would consider to be the fathers of neurofeedback, Dr. Joe Kamiya and Dr. Barry Sterman. Dr. Kamiya found that humans can regulate their alpha rhythms. Dr. Sterman found that cats who were exposed to monomethylhydrine and were getting seizures because of that exposure were actually reducing their seizures when they were inadvertently being operantly conditioned of the sensory motor rhythm. And that really is the beginning of the operant conditioning model of neurofeedback. Again, there's more about these two gentlemen and many other people in your textbook, and I'm hoping that you will read up on them, and if you have any questions, by all means, I am very happy to dialogue. Now we're going to talk about the basic tenet of neurofeedback, which is operant conditioning. But we have to start first with classical conditioning, with classical Ivan Pavlov and his dogs. Classical conditioning became named that simply because when operant conditioning came along, we needed to classify conditioning as something else, so it became classical conditioning rather than, current conditioning. So classical conditioning is based upon a physiological response, a knee-jerk reaction, a reflex that the subject is unaware of. So what generally happens is the subject is conditioned to something, a bell, And they know when the bell, for example, with Pavlov's dogs, they know when the bell goes off that they're going to get a treat. And so they begin to salivate almost immediately when the bell goes off. Well, then they started noticing that the simple presence of Pavlov meant that they were going to get treats. And so they started salivating simply by his presence. That would be the unconditioned stimulus. And their unconditioned response to the salivation to him simply showing up. And so it sort of overrid the initial response. And then you can take away the unconditioned response, and the subject would continue to respond in the same way. Acquisition is simply the acquisition of learning. The task is completed. The subject knows or responds in the way that we would expect the subject to respond reliably. Extinction is about the client not getting any more stimulus, whether it be conditioned or unconditioned, and the response going away, or the reflex going away. It stops happening. Generalization is when one learns something, maybe in a research environment, and then, or in the neurofeedback clinical office, and then goes out and learns how to use that skill outside of the clinical experience. So these things are very important for neurofeedback. Acquisition, the brain learns how to maintain a certain brainwave frequency for a certain period of time. Extinction, which doesn't happen in neurofeedback, not in the same way that medications. If you stop taking medication, your response to the medication extincts. That doesn't happen with neurofeedback. If anything, after having done neurofeedback, the neural pathways and the state changes become even more and more profound. And generalization, they're doing neurofeedback in your practice. They're learning to maintain alpha, theta, beta, SMR, whatever the training is, and then they go out into the world, and an event occurs that inclines them to go into the state that you've been training them to do. So a perfect example of conditioning is a very happy dog. Look at that dog. That's my dog, Wally. And he's a very happy dog having fun on our boat. And he knows we're going to go out in the water soon, and he loves to chase the birds and carry on. And so he's already anticipating his response to the stimulus of going out there. Now we'll move on to operant conditioning. B.F. Skinner, as you all should be aware. So now what we have is voluntary control. So it's not salivating anymore. It's a conscious effort. It's an I want to do this. Two of the important aspects of operant conditioning are punishment and extinction. We talked about extinction in classical conditioning, and it's basically the same thing, that the removal of any stimulus stops the response. Punishment, on the other hand, can be positive or negative. It's any stimulus that causes pain or discomfort that will abort a responsive behavior. Now, there are positive punishments as well as negative punishments, and it's very important to understand that a punishment can lead to a positive response. So positive and negative reinforcement and contingent and non-contingent reinforcement are important aspects to understand in operant conditioning for neurofeedback. So positive reinforcement is any stimulus that elicits a positive stimulus that elicits a response, or a negative stimulus that would elicit a response, or the removal of a punishment in terms of negative reinforcement. Contingency. Contingent reinforcers are directly related to the behavior, where non-contingent reinforcement is not directly related. Contingent or specific could be the actual neural feedback, the actual operant conditioning of the brain. Non-contingent or non-specific could be the relationship between the therapist and the client. This is a very handy graph here to help you to remember whether a reinforcement or a punishment, positive or negative, is something that will stimulate a reaction or inhibit a reaction. And you can see that anything that's a reinforcement, whether it's positive or negative, will increase the likelihood of behavior, whereas anything that's a punishment, whether it be positive or negative, decreases the likelihood of behavior. We're now ready to talk about what is the EEG. If you look at this diagram here, you can see that the 1 Hertz wave is twice as long as the 2 Hertz wave. EEG is measured in Hertz, which are cycles per second. So the dotted lines going down are 1 second intervals. So the top one, 1 Hertz, the wave starts and finishes where the wave starts and finishes within the second is only 1 time. And so that would be 1 Hertz per second. If you look at the graph below, you can see that the wave actually travels 2 times during the course of the second. And so you can see 2 peaks and troughs, 2 complete cycles. And that is the frequency of the EEG. Think of the frequency as the width of the EEG, the length of it. It's measuring how many times in the course of a second the wave is actually happening. Now we have to measure the height of the brainwave. And you can see in this case that the top one is much narrower than the bottom one. So the amplitude of the top one is smaller than the amplitude of the bottom one, and in degradations in between. So we're measuring how high or how wide the wave is. So we've looked at how long it is, now we're looking at how high it is. The top one is most likely a high frequency or fast waveform, and the bottom one is likely a slow frequency. The slower the frequency, the higher the amplitude generally. And so that's why I'm making that assumption. We'll start with the slowest frequency range, which is delta, which is generally 0.5 to 4 Hertz. It's different in every book and every article that you read, but that's what we're going to use for this course. It is most indicated in sleep, and we're going to talk about that a little bit more in the next slide. It's very much indicated in metabolic activity in the pyramidal cells. It is very common in infancy. It's related to the recovery of TBI. Generally, if you're working with someone who has a traumatic brain injury and it's right after the injury, you really don't want to train down the delta because the brain needs to basically slow way down in order to heal. It is of cortical origin. So here is the slide about sleep that I was referring to in the last slide. And the way that this is broken down is that you can see that the 5 different stages, stage 5 being REM sleep. The characteristics of that stage of sleep, the brain wave that is most associated with that stage, and the amount of the entire sleep cycle that actually you are in that stage. And I was reading from the bottom up. So basically a complete sleep cycle is about 90 minutes. You start off in stage 1. That's the very beginning of sleep, and in fact, you're not necessarily fully asleep at that point. That's when your muscles twitch, and it lasts for only about 5 or 10 minutes. And you can see that delta is not associated with that stage. It's associated with stages 3 and 4. The second stage is when you're going to start to see the K complexes and the truly sleep spindles that are also associated with SMR, which we will talk about later. And you spend most of your time, more than half sometimes of that 90 minutes is in stage 2. And so you can see stage 1 and stage 2 are similar to each other, and stage 3 and 4 are very similar. It's the transition into the very deep, deep sleep. It is generally what happens after sleep deprivation, and you go into the slow wave sleep a lot sooner if that's the case. And then lastly, REM sleep, which is when you are vividly dreaming. And that's when your brain is actually, or what we assume is actually consolidating the day's memories. The next frequency range up is theta, which is generally 4 to 8 hertz. It is seen in inner reflection or reverie. You would see it in the back of the head. In the front of the head, you would see it when one is attending to outside stimuli, which is why it's very common in attention deficit, because one has trouble bringing their attention internally and are so susceptible to the sounds and lights and movements that are happening outside, and why one can't attend. It's involved with tuning out, inattention, daydreaming. It's also involved in depression and pain resolution. It is considered an internal hyperarousal when you are involved with theta, and internal meaning your body, not necessarily your brain. It's involved with creativity in the same way, in the same areas of the inner reflection and reverie. It's very much involved in memory formation and recall. It is one of the aspects of theta-beta ratio, which we're going to talk later on in another section, and that is a very popular protocol that is used for attentional and learning issues. And it is of cortical origin. The next frequency range is alpha, which is generally considered at 8 to 12 hertz. It is very prominent with eyes closed in the resting state, where you would find the dominant frequency generally in the occipitals. It's involved with creativity in the same way that theta is, and daydreaming, and it's also indicated in anxiety. So if you've got too much alpha when you shouldn't be having too much alpha, that is definitely very anxiety provoking. Very high arousal, PTSD, very common. It's also involved in meditation and inner calm, when you find that in the back of the head, when in fact that's what you're attempting to do. It's involved in depression and fogginess, and it is of subcortical origin. So you can see that the lower frequencies, the delta and the theta, have cortical origin, and alpha and the next few they have subcortical origin, generally in the limbic and thalamocortical, or the thalamus. And then we have beta, which is 12 hertz and above. Beta is indicated in focusing, when we have our attention and learning issues. Generally, there's not enough beta. It's involved in analyzing, and the higher the beta dominant, as it were, the more internally focused the person is. Sometimes to the point of pathology. It's involved in depression, in that generally there isn't enough of it. It's involved in sleep disorders, that also there isn't enough of it. It's involved in learning disorders and anxiety if it's found to spindle. Beta in the 10 to 20 hertz range is associated with ruminating. More often than not, if you have a client who is a ruminator, a worrier, you will find excess alpha in the 20 to 30 hertz range, generally in the frontal areas. It's generated either cortically or in the brainstem. And you can see as we've been going through these frequency bands that the waveforms are getting closer together. And that's because the frequency is measured in cycles per second. And so every second there's going to be a lot more wave cycles than, say, back in delta. Now we're going to talk about a few wave morphologies. This is very important. SMR stands for sensory motor rhythm. It's found in the sensory motor strip only. It's found generally in 12 to 15 hertz. It can be found a little bit higher or a little bit lower, but it's an actual wave form. So if you look at the image of this waveform at the bottom, you can see that there's a very specific spindle that is occurring that is of SMR that is embedded within the rest of the frequency record that we're looking at right there. It's involved in motionless and being quietly alert. And if you find 12 to 15 hertz in any area other than the central motor strip, it is not considered SMR. It's considered beta. SMR is also called low beta at times. It's of cortical origin, and in a couple of slides we're going to talk about mu. And since mu falls in this very similar range, in the same kind of area as SMR, some people question whether mu and SMR are similar. In the little tiny image that we have here to the right, on the top is an EMG recording while at the same time we were doing SMR training, which is the bottom, the orange graph. The SMR relative power in this particular screen was most high at about 20 to 27 minutes or so. And at exactly the same time, you can see that the amplitude of the EMG measurement was much lower. So when your SMR goes up, generally that is because of and will also stimulate motionless or relaxation. It's excellent for people who present with that are hyperkinetic. It's a very calming treatment, and is also very good for sleep disorders, because some people consider SMR to be the awake sleep spindle. And so they're very similar, and if you encourage SMR, you will encourage sleep spindles as well. Here we have the sensory motor homunculus, which homunculus stands for little man. This is one half of it. It's a coronal view, so you can see an MRI scan of where this is over there on the right bottom. And what this is a schematic of is the amount of real estate, basically, that the homunculus uses for the different parts of your body. So, for example, if we're looking on the right side, actually it's similar on both sides for the most part, and you can see that the hands and the lips and the mouth and tongue take the largest portion of the surface area of the homunculus. That's because these are the parts of our body that are have the most intricate movements, and so we need a lot of space in the brain to create and send those messages to those motor areas. Mu is another morphology. Again, it is not a frequency range. It is a morphology known as the Wickett rhythm. You can see an example of it here at C4 in this EEG recording. It generally is in about 9 to 12 hertz is when, the frequency at which it occurs. And it is also found in the sensory motor strip, just like the sensory motor rhythm, which is why it's sometimes confused or compared to the sensory motor rhythm. There is some work being done about this down in San Diego with Jaime Pineda and Michael Linden. that where they're looking at the dysregulation of mu in autistic spectrum disorder, and thinking that it might be associated with their mirror neuron system. So the mirror neuron system is about reflecting other behaviors, behaving socially correct, and being able to mimic. And this is an area that has been dysregulated in ASD for, it's one of the main features of ASD. Gamma is the fastest frequency. It generally appears globally and in bursts when one is either deeply meditating or resolving some cognitive task. And it generally happens and then it stops happening. It's associated also with sensory, cognitive, and motor integration. So it's very much involved in new events and being able to assimilate them. It's generally considered to be 30 hertz and above. It's also known as fast beta. And some people will even say that it's really in the 45 hertz range. It's very important to think about where in the brain the waveform is occurring. As I mentioned, for alpha, that is indicated with anxiety as well as meditation. And so you have to know when it appears and why it appears. You need to know if it's showing up at F3, what goes on in the brain under F3. And we're going to talk about that in other sections as well. For example, parietal theta is great for reverie, but frontal theta may cause attentional issues. Frontal alpha may cause anxiety and is very different than posterior alpha, where it has been associated with a meditative state. So remember your lobes and recall what their basic functional purposes are, and you'll be able to connect what that frequency profile is, how it's affecting what's going on underneath that part of the brain. We're going to talk about this a lot more in other sections, but because I mentioned it just a bit ago about knowing what's going on underneath the sensor, I wanted to bring this to your attention. These two images work really well together. The colorations of the lobes in the lower right, and then their functional story on the upper left there. So for example, the frontal lobe is involved in reasoning, planning, organization, personality. That's where Broca's area is, which is the speech area, writing and movement. Not only that image also points out where in the frontal lobe those activities occur. The parietal lobe is associated with your sensory motor cortex and speech understanding, which is your Wernicke's area. Your pink picture there, the temporal lobe, is involved in hearing and smell and memory. Your occipital, the green area, is involved in vision and visual processing. So these two images together, I think, make a strong statement, and memorizing this image here of the functional areas would be a good idea. Stop using negative reinforcement or I'll kick your ass. Anyway, this is the last slide of this section. Go ahead and answer your questions and email them to me at cynthiacurson@gmail.com.